Copyright Stanford University, all rights reserved.
Good afternoon. Welcome to the 7th Annual Norman E. Shumway Visiting Professorship. Dr. Shumway came to Stanford in 1958, and over the next decade, together with Dick Lauer, and through diligent experimental and translational research, he founded the field of cardiac transplantation. In 1968, Dr. Shumway performed the first human heart transplant in the United States. Together with his colleagues, such as Sharon Hunt, Phil Oyer, and others, many of whom are seated here today, Dr. Shumway continued to innovate and refine cardiac transplantation, to develop it into a widely utilized treatment, which to this day still stands as the gold standard for end-stage heart failure, and has over the decades saved countless lives. Dr. Shumway is the recipient of every major award by our major cardiothoracic surgical societies. He was also notable for his teaching skills in and out of the operating room, and has trained a cadre of talented surgeons who have gone on to become themselves international icons in this profession. Through the generosity of the Shumway family, in 2008, this visiting professorship was established to honor a visionary scientist, pioneer, surgeon, educator, and a great man of humility, humor, and compassion. Today, we celebrate Dr. Shumway's legacy again with the 7th Annual Visiting Professor, Jeff Rich. Dr. Rich received his biomedical engineering degree from the University of Illinois and his medical degree from the University of Chicago. He then did general surgery at the Massachusetts General Hospital and conducted his cardiothoracic surgical training here at Stanford. He then went into practice at Norfolk, Virginia, where he's been for the last 20-plus years. There are a variety of accomplishments in Dr. Rich's CV, but allow me to highlight just a few of them. First and foremost, he was involved in the Society of Thoracic Surgeons, one of our foremost professional societies in cardiothoracic surgery, and he rose to become the president of this society. He was also very involved with the federal government in healthcare reform and became the director of the Center for Medicare Management in CMS within the Department of Health and Human Services. And within that role, he personally managed a budget of $700 million for his staff of countless people, and this supervised the fee-for-service provision of payments to healthcare providers of over $450 billion. He has a very interesting section in his CV that we don't typically see, and that is the section on congressional testimonies. So he's had to go in front of Congress multiple times to speak his opinion. On work that he's done with value-based purchasing and accountable care organizations, he has been a significant part of the writing of the Affordable Care Act. And he has approached his entire career with the overarching themes of advancing the quality care of patients, reducing healthcare costs, and providing fair reimbursement. So it is my distinct privilege and pleasure to introduce Dr. Jeff Rich to give us today's lecture on The Perfect Storm, the Affordable Care Act and Repeal of Sustainable Growth Rate Formula. Dr. Rich.
Thanks, Dr. Wu. That was a very kind introduction. And you can't be humbled enough by being here and being the Norman Shumway visiting professor. He was just a guiding light for me in my life, in my professional career. He was an incredible mentor. And one of the things I admired most about him was his teaching ability. And as you can see here, he and I are not butting heads, but he's doing a case with me, and he's on the left side of the table. And at the top of the table, you can see the anesthesia screen. And that was him. I never did a case at Stanford when I wasn't the primary surgeon. And I think that's a cultural part of Stanford and why they have trained so many incredibly good surgeons over time. So I have a story to tell. This is an interesting story, and I want to take you through some of it because you'll never read about it. The history of U.S. health insurance, a lot of which I gained from the CMS library, through a locked door, and Medicare expenditures and the challenges that we have and had, the Affordable Care Act and how it has surfaced as a driving force now for healthcare change. And then the repeal of the SGR, which is really the non-repeal, because as you'll hear at the end, it was about to be repealed and then it was pulled back. So we're still waiting for that. So the history of healthcare insurance, after the First World War, we didn't have insurance for anybody. The soldiers were coming back, people were injured, we didn't know how to care for these patients, and the debate began within the United States, and we said we need to have some sort of socialized or open system of healthcare insurance. And that debate just went on, as you might imagine, for years within Congress until the 1930s when we hit the Great Depression and the great debate resurfaced. And it was private versus government insurance and the public option. And why did it surface in the 1930s? If you talk to sociologists, during a point of Great Recession or, like we've just had, or depression, people have lost all of their money. They don't want to lose their health. And so healthcare becomes so important from a social society standpoint that this has generated a lot of change in our country. So the public option was put on the side and the private payers came through. And in the 40s, during the Second World War, we saw a rapid expansion of private insurance. And why did we see that? Because during the war, there were wage price controls. So if you couldn't, what the government didn't want was private companies cannibalizing workers to come and work for them to do other things in their industry and go away from the factories that were making ammunition and guns and all the things that were supporting the war effort. The only thing that they didn't control was health insurance. So private health insurance got more robust and bigger and better because it was the only way that they could attract people from one industry to the other. And so that created a locomotive that left the tracks that we see still today. And federal funding for state payments started in '50. It was the Medicaid prototype. The most important thing, the medical assistance to the age with low-income elderly. Now you're talking about dual eligibles here, which some of you may or may not know is a term, but those are people who are Medicare qualified and Medicaid qualified because of their low income. But in 1965, we finally had the Social Security Act established Medicare and Medicaid respectively by by President Johnson. And this was a great debate going on there, and actually Dr. Cooley was opposed to it for many years and actually lost the debate with Lyndon Johnson. And so the Act was signed into effect in 1965. So the importance of this slide here, it was signed into law in the middle of 1965, and by July 1st of 1966, 19 million people were enrolled. Let's talk about the Affordable Care Act. Signed into law in 2009, 2014, 9 million people were enrolled. So it was an incredible amount of work that went on at CMS, or at that time HCFA, to get this done. And it's made up of two parts. The hospital insurance Part A and a supplementary medical insurance Part B, which pays doctors and a variety of other services. And that's the traditional fee-for-service program, which is the one that I ran when I was there. So how's it paid for? Medicare fee-for-service Part A, that comes out of payroll taxes. That's the 3.6% that each and every one of you pay. You pay 1.8%, and your employer pays 1.8%, and it goes into a true trust fund, and it's dedicated funding, and it's called the HI Trust Fund. Part B is funded through general tax revenues. So when everybody has their income taxes collected, the government shovels money from one wheelbarrow into another to pay for the Part B side. There are some supports from beneficiary premiums, so all of your Medicare patients are paying about $100 a month, and that goes into the trust fund as well, but it's not as robust. It's a fund that kind of evaporates at times, and it's not really positioned there stably. So the thing is that we built the system based on the volume of overvalue for services. We had misaligned provider incentives. The more you did, the more you make. You didn't really care if the quality was good or not. You did care. Some of you did care. It's led to increased utilization of all services. So if you create a system that pays for volume, what are you going to get? A system that creates volume in these services. It pays for avoidable complications. So when you make a mistake, you get paid for making that mistake. In some cases, it pays too much for services. So this is a big thing that we had to do. I had to do manually at CMS. I'd look at the ledgers every year and things that seemed way overpriced. They had to bring down their prices for physician services. We often paid for unnecessary care and testing, so it was inappropriate. We paid for duplication of tests. You all have had patients transferred in from another hospital that already had a whole battery of tests that you don't have access to, and so you repeat them when you get here. So now you're duplicating a lot of resources that were necessary to treat that patient. There was poor care coordination, to be honest with you, and that's where our healthcare system failed and still fails now. And it favored us, specialty care over primary care, and it led to variations in cost and quality. So here's a map of costs for Medicare beneficiaries. The brightest red are the most expensive areas in the country on a per capita basis, and this is a map of quality, and the gray areas are the worst quality. So you overlap them. You're paying in the areas with the highest cost, you get in the lowest quality. And this was something that drove the Secretary of Health crazy when I was there. He would say, we've got to do something different, and we've got to do something to change this. We need to change the paradigm, the way we're treating patients and paying for health care, and we have to reduce costs, and we have to improve quality. So what happened? This is it. It's just healthcare spending, the American style. It's just up and up. It's exponential. Ever since Medicare was incepted. So it grew at 7 to 9% for every year the Medicare program was up and running. It has currently slowed down to about 4%. Most people do not believe it's due to any of the healthcare policy, but to the recession, the general effects of the recession. It's sort of a hangover from that. And Medicare went up as well. This is what my budget was, as was mentioned, $460 billion. Right now, if you do the numbers, Forbes magazine in Q1 of 2014, we spent $3.8 trillion in health care. That's private and public. Medicare and Medicaid together from the government side is up to $1 trillion. Then you have to add in the state support for Medicaid, which is another $500 billion. So we're up to about $1.5 trillion just for government care of the Medicare and Medicaid patients. And are we doing a good job as a percent of GDP? These are all the countries, industrialized countries in the world, and some not. But look at what's happening with us. We're up to 18% now. And what's interesting about this, the dark blue, is government spending, and we're looking pretty good. But what's really pushing it is the private healthcare spending. Go back to my comment about the 1940s and healthcare insurance and how that has driven healthcare spending in this country. People with, Cadillac health plans and things like that. Some of that's reversing now, but it's still, we still are 50 to 60% higher than any other country. And on a per capita basis, we're not getting any better. We're spending almost twice as much as other countries in terms of per patient basis. And if you look at World Health Organization statistics, and you could argue all you want about it, we don't look very good. The best thing we do is we order more advanced imaging than any other country in the world. So when I was at CMS, this is what we were faced with. It was about that time, the straight line is 2.7, and they move over once, and now you see the line starting to separate, and that's was deficit spending. So I entered into the era of deficit spending for Medicare, and I could just see that as this thing unfolds. I have a little granular picture on the face of a Wall Street Journal saying, it was my fault because I was the first one who promoted all these policies that caused deficit spending. And this was what the Office of the Actuary, Rick Foster, gave to me. He said, this is what you're faced with. I asked him, what does this all mean? He goes, here, 2008, straight vertical line. He said, you're bankrupt in 2017. And it was just a startling moment because I had to write letters to every senator, every congressman, and the president saying that we have a Medicare funding warning and that we're going to be bankrupt in 2017. And as we go through this talk, just remember that date because most of the enactment of the Affordable Care Act happens by 2017. To try and avert this depletion of the health insurance trust fund. So what do? You can increase revenues. That's just a fancy way of saying we're raising taxes. We could decrease expenditures, so we reduce entitlements. We didn't do that with the Affordable Care Act. We increased entitlements. Or you reform the payment system and the delivery system. And to do anything less than that, if you wanted to do it with taxes, you'd have to have a 233% increase in taxes, or a 53% immediate reduction in the health care. So you got to send half your patients home today and stop treating them, and don't ever see half the patients that you get consults on. So that's not sustainable. So the years that I worked in DC and at CMS, we developed the value-driven health care, which is basically transforming Medicare from a passive payer to an active payer or purchaser of higher quality, more efficient care. Makes sense. But the Social Security Act doesn't allow that. The Social Security Act says you can't pay for quality. You just have to pay for services in the volume of services. So it was a collision, I mean, of intense purport, and you needed to have legislative, you had to act of Congress to change that, which eventually happened. And so by the time we left, this was on 4/47, the Friday before Obama took his oath of office, we put in there these guidelines for healthcare in the United States: quality measurement, resource use, and value-based purchasing. I was pretty much the primary author on value-based purchasing and was the secondary author on the other two, and those are available on the CMS website. So would there be change? You say, well, you're leaving, and doesn't administration change? So when you change an administration, you have transition teams. So the transition team came in, Obama nominated people, they came in, we had 300 meetings and generated about 4,000 pages worth of documents to help transition healthcare in a safe way, and gave him a roadmap saying, in 5 days, these are your dangers. In 15 days, this is what can happen. In 5 months, this is what can happen. And in 5 years, these are your goals and your maps, your roadmaps for success. So what happened was that they wrote the ACA, the Affordable Care Act, came out on Christmas Eve, and it was immediately revised. But within it, the most important thing was Title III. I mean, I didn't deal with any of these other things, and entitlement wasn't my strength at all, but improving the quality and efficiency of healthcare in Title III was everything that we turned over to him. And a lot of it was almost verbatim. It showed up in the law. And so I was amazed that it got to that. And so now we're talking about increasing quality, paying for quality, and reducing cost, and paying for providers to try and align themselves with hospitals and others in a system that's going to create efficiency of care. And it really focused on this in a very meaningful way, outcomes and cost. Remember, as I said, the Social Security Act did not allow this to happen, but now it has changed through an act of Congress. It was going to reward communication and collaboration, because that's where our healthcare system has failed over time. New care delivery models, and reorganize providers into different ways of providing care. Accountable care organizations, clinically integrated networks, and moving away generally from a fee-for-service system, which is what has driven healthcare to where it is right now. And all these payments are going to be dependent on comparative value. There are going to be demonstrations and pilots and incentives for new care delivery models. Scott and I were talking about global payments earlier. A lot of it is written in there. There's a whole provision in Title III that promotes the use of bundled care and bundled payments for new healthcare delivery models. So what is the impacts? Because I think we're talking now about part one of our perfect storm, impacts to hospitals and physicians. The impact on hospitals, there are 3 provisions I just want to bring forward that are pretty much can be very destructive to your hospital if you don't have your providers engaged in it. And there's hospital-acquired conditions, value-based purchasing, and readmission rates. And I want to remind you that different than physician payments, hospitals get about a 3.2 to 3.6 annual update based on the Medicare Economic Index, which is a market basket of economic indicators for healthcare delivery. So hospitals every year are upticking. Physicians don't have that at all. We don't have that privilege at all, and we'll talk about how we get paid. Hospital-acquired conditions, these were things that, you would look at and say they don't happen. They happen a lot. And so in the early parts of this, you would not get paid when you pay a hospital for a DRG for cabbage. If you start putting in, say, mediastinitis, that would get kicked out. So you wouldn't get the additional money for that particular complication, or if you had a pressure ulcer, that would come out. It was pretty simple rule, but it created a lot of angst among providers, but it was a very good rule. What had happened was that in the ACA, they went over to rate-based measurement of HACs. So you're going to get, if you're in the top 25% of those who are having problems, 1% of your market basket, or 1% of your DRG payments will be reduced on an annual basis, and that becomes a heck of a lot of money for a hospital. And that's implemented now. Hospital value-based purchasing is a program that I worked on and finalized and put to Congress. It basically looks at performance measures in these clinical areas, including hospital care, including patient satisfaction scores. And then your hospital will get a roll-up of all the scores, and you'll be put onto an exchange function, and there'll be a decision made about whether you can get your money back. So what happens is as I told you, there'll be a withhold. So every year your 1% withhold is held. and it rises to 2% by fiscal year 2017, and you have an ability to earn it back. You could get back to the baseline, but you have to do it. You have to hit those performance measures, and that's where hospitals need, provider help, physician help. The good thing about the statute is it's budget neutral. So written into the legislation is that the money that doesn't return to the hospitals has to be not to the poor performers. If it can't go to the poor performers, it gets redistributed to the highest performers. So there's actually an upside to this for a hospital if you're a good performer and in the top 10% of your peer group. And then the readmission program, this is a hot item, and I know Sharon knows this for heart failure. People are readmitted all the time, and so looking at MI, heart failure, and CABG, readmission rates are being tracked right now, and if you have readmission rates that are excessive, you could lose 1, 2, and then 3% of your annual update by 2015. So what are the impacts? Hospital impacts, let's just take those three things: hospital value-based purchasing, readmissions, and hospital-acquired conditions. By 2015, that's tomorrow, your hospital can lose 5.5% of their DRG payments. That is big. So what is the average profit margin for a hospital in the United States? 5,535 acute care hospitals. It's a restaurant, about 3.5%. So if you take 5.5% away, you're going to put a lot of people out of business unless they can earn their money back. And by 2017, if you add in the other thing, the health information technology, the meaningful use, and the other just non-reporting, it could be up to 7%. So, meaningful use being electronic health records. I know you guys have Epic here. Just imagine, I just called DC the day before yesterday to find out how many hospitals are doing meaningful use in the United States. 3%. 97% of hospitals do not even have a meaningful use category that they can fulfill. So why am I telling you this? Because the physician workforce needs to work with the hospital. We're responsible for these measures, and we'll drive quality improvement and patient management and create profit stability or instability for your institution. And as I always say, I want to work in a stable institution. I don't want to work in an institution that is, basically on the verge of bankruptcy, because that doesn't help me or anybody. Part two is the impact on physicians. We had the three areas I wanted to focus on was physician quality reporting system, the value modifier, and meaningful use. So you all know what PQRS is. You've been doing it for a while. I assume you guys are doing it here. You report to CMS on the basis of clinical measures that you choose, and you were getting paid for reporting. And that reporting system started back in 2007, 2008, the first time we turned the crank. About 19% of physicians were reporting. You basically were reporting clinical data parameters that you weren't getting paid for on performance. It was just a reporting-based system. The incentive bonuses have now gone away. In 2015, if you're not reporting, 1.5% reduction in physician payments, and by 2016 and beyond, you got a 2% reduction in physician payments for just not reporting. The value modifier, it's a differential payment for physician groups. Right now, groups using a modifier to the physician fee schedule. It's budget neutral, so it's robbing Peter to pay Paul. There's no new money here for any kind of incentive bonuses. And it's based on the quality of care compared to costs. So this is right off the CMS website. You can see that it's being phased in 2015. It's for groups of 100. So most of you in this room are probably being impacted by it because you're in a group of 100, maybe. Not cardiac surgery, but if you're in a multi-specialty group. It's based on reporting in the physician quality reporting system, and in 2015, there'll be, as I said, 100, you have to have 100 patients or providers within the group. The thing that I want to scare you about is the cost and the quality measures already been defined, and this is how they defined it, and they're defining it on their own, and we've kind of lost control over some of this, particularly on the cost side. They're defining it through claims-based stuff, and they're coming up with a value modifier amount that's going to be applied not to just the CABG, but to all the DRGs that you submit claims on, for everything that you do, heart transplants all the way down to, a lymph node biopsy. Everything will be modified by that. And so this is the grid for reward, and this is the grid for penalties. You can get as much as a negative 2% to your annual fee schedule if you are high cost and low quality, or if you're high quality and low cost, you can get a plus 2%. So those definitions have already been decided by the Secretary of Health for us. So you have to be on the lookout for this and make sure that you understand what quality measures you're being held accountable for. And the way that they do that is just look at what your primary codes are that you're submitting, and then they assign patients to you as a level of attribution. So maybe 3,500 patients that the cardiac surgery department has operated on, and that will be assigned to you, and then they'll look at all the costs, and they'll see if how you compare to peer groups, and they'll create a value modifier for your entire department. So meaningful use, that's electronic health records in your practice and office. There were early incentives, now they're escalating penalties, and this one's pretty bad. And we moved into, within Affordable Care Act, clinical quality measures, clinical stage 2, and they're automatically reported. They've always been determined. They're being reported through a claims-based system. You have no control. In fact, we have lost control of this one because government has taken over on that. So what happens for the payment system, for physicians? You got the PQRS, the incentive is going away and the penalties coming in. You have electronic health, electronic prescribing, which is rolled into meaningful use. You have meaningful use, which was you were getting $18,000 per physician if you were participating in electronic health records. And now you'll get up to a -5, almost 5% by 2017. That number is still at play. And we have the value-based modifier for groups of 100 this year, and it moves to groups of 10 next year. And beyond next year, it goes to groups of 2 or more. They're not going to single out a single provider, a solo practitioner, but it's there. By 2017, it's down to groups of 2. So every physician will be impacted by this. So their total physician impact, as you can see, is up to 6% by 2015 if you're not watching carefully and performing well. And these will serve as adjustments to your fee schedule. So if you thought that having a negative or a 0 update is bad, what do you get, a 6% decrease? I mean, that will destabilize anybody's department, anybody's place of work. So part 3 of the perfect storm is the SGR, the Sustainable Growth Formula for physician payment. So it was developed yet as another answer to trying to control the volume of physician service. So in 1966, Medicare came in, said, okay, we're going to do a reasonable charge basis. So you got to submit your charge. Dr. Mitchell could submit his charge, and you get paid if it was reasonable. That didn't control the volume at all. It continued to grow exponentially, as you saw. And in 1992, they said, well, we got to develop something different. So the resource-based relative value system was developed at Harvard, and it was implemented. And it had no impact on the volume of physician services. So look, 1992, have you seen a change? Nothing. Nothing stopped the growth. So they said, okay, let's move to a new paradigm. Let's go with the sustainable growth rate formula. It was introduced in 1997. It's tied to GDP. So we are allowed to grow as much as GDP, which is 2 to 3%. If we go beyond that, then we are charged for excessive growth in the physician payment side. It's not just physician payments, though, because in the Part B schedule, there are a lot of other things like end-stage renal disease, dialysis centers, ambulances, clinical labs, but it's on our backs. And so you will, every year, if you go above GDP, then we get charged a penalty. And each year, the penalty keeps rising. So now it's about 25%. And every year we hear this, you got to have a fix, a patch onto the physician payment system. And we just had another one. And so most people feel that this is an unsustainable payment methodology, is unpredicted payments. It's the inability to do practice management when each year is an unknown. You don't know if you're going down 5% or up 5% or being budget neutral. Congress has already spent more on temporary patches than it would cost them to repeal SGR. In the past, SGR was worth about $250 billion. This year, you'll see in the next slide, it's on sale. But they realized that continuing payments to MDs on the SGR is flawed. It's a major headache to them. They got to go to have congressional hearings every year about this. And honestly, it hadn't worked. In 1997, we're still growing. We're growing at 7%. It's just leveled out, as I said before, to 4%. But it really hasn't controlled the volume of physician services. So the spending cycle is still moving along. The machine is churning out health care. So the formula was to be repealed. And as I said, prior years was $250 billion. It's currently on sale for $116 billion. And at $116 billion, Congress said, it's not a bad deal. Why don't we consider just repealing this? We'll get rid of this headache forever, and let's change to a physician payment system that rewards quality, and allows us to create different ways of paying physicians other than doing this crazy formula that we have right now. So there was intense interest in eliminating it, replace what we had gone to and worked on, and I had worked on a lot of the congressional staffers was, why don't we get paid like the hospitals? How about the Medicare Economic Index and apply it to us as physicians? We would get a dependable 3.2 to 3.6% increase. It would allow predictable increases in physician payments, and we'd be able to stabilize our workforces, our practice, our institutions. And the thing that I wanted was alternative payment models. So what are these? The thing that I didn't want to have happen was to have a system that made us or held us hostage. Because the STS and the ACC have the great, robust clinical databases and we could apply cost to our database, and we could create alternative payment models that will let us take healthcare in a different direction, improving quality, lowering costs, but rewarding us to do that. So they bought it. And so, I ended up getting asked to do a congressional testimony on STR, and all of these things I presented and were discussed there and were supported by a lot of other medical societies. So 3 bills came from the committees of jurisdiction. That's the Senate Finance, House Ways and Means, and House Energy and Commerce. And all 3 bills repealed the SGR. And they implemented a revised fee-for-service system based on quality. And they all called for the development of alternative payment models, which all sounds pretty great, right? Until you say what actually happened. Senate Finance, 10-year freeze on physician payments, 0% for 10 years. The House Ways and Means, 0.5% for 3 years, and then just negative or 0 for the next 7 years. And then the House Energy and Commerce was a little bit better. It extended that into a more number of years for the 0.5% increase. But to me, I saw this, I couldn't imagine. I was like apoplectic, like how is this a payment fix? So you get a 0% increase for 10 years. That means if you take the cost of living increases and just multiply it by 10, you're getting a 30% reduction in your payments in a decade. This is a decade, it's not a year. It's an entire decade, and that's what they came out with. What really happened next was the House Ways and Means and Energy Commerce agreed on a bill that you see here. 5% for 3 years and 0% for the next. It passed in the House. It was dead on arrival in the Senate, because they put in their provision to eliminate the individual mandate for insurance. That's in the Affordable Care Act. That's the 53rd time the House has voted on that. It's not the first, it's the 53rd time they tried to eliminate this. And it was going nowhere, but the bill basically died. And the Senate Finance didn't even put forward the bill in the Senate. So what they did was do a 0.5% increase for 1 year, another patch. And what we got was basically no alternative payment models. So for 2015, the perfect storm, we got a potential negative 5.5% for hospitals, 6% for docs, 0% update for 10 years, and we have lost all alternative payment models for the moment. And I'll speak more to those because those are, I think, where our next happy space will be. So what's next? You get asked the wizard, I don't know, because all new legislation that's pending goes in the trash. When Congress changes over, anything that was out there just gets thrown away. And it has to be resurrected all over again. And even if this bill passed in the Senate, it could have gone to the president, and he could have done a pocket veto, which means he just put it in his pocket and ignored it until the new Congress came in, then he could just throw it in the trash. And that's what a pocket veto is. So the problem is, I hope that the SGR debate will resurface. The cost to eliminate it is rising as we speak. And it's likely that our fee schedule is going to be pretty flat for a long time. It's quite frightening, actually. So is there an upside? Well, if you're good, your hospital's good, and you work with your hospital, and your hospitals outperform the rest of the country, and all that money that others didn't earn back is going to get redistributed, then you have an upside. And physicians who perform well can earn up to 2%. And the last time we had a 2% increase, I can't tell you. It's 20 years ago, maybe. You could develop accountable care organizations. I don't know if you have one here at Stanford. Clinical integrated networks, which is what we're doing at Sentara. We have 2,500 physicians who are doing purchasing agreements with the city of Virginia Beach and other healthcare payers. And the thing that I pushed hard for was the shared savings model. So if you work with your hospital and your profit margin goes up because of the work that you do for improving quality and lowering costs, you should be able to share in those savings. And that was the thing that I worked on for a year when I was there with the Office of General Counsel and and the Office of Inspector General. So you could earn up to 25% of your Medicare allowable if you create savings that could be documented and that the hospital is willing to share with you. So that's the shared savings model. And then we get into the alternative payment models. And the alternative payment models, the Center for Medicare and Medicaid Innovation got $10 billion in the ACA to go ahead and create alternative payment models and new healthcare delivery payment systems and pilot programs. They worked hard in the first 3 or 4 years on primary care. And then they called me and said two things. One, can you come back and run specialty reform? I says, yeah, I did that trick already. Why don't we figure something else out? So they outsourced it to Brookings Institute. Mark McClellan's a former administrator who I worked with a lot on these policies, MITRE Corporation and RAND. And they have identified cardiovascular disease, that space is their primary goal, to create their first wave of alternative payment models. And a technical expert panel was convened by Brookings. I'm a member of it. I'm representing CT surgery. There's some cardiologists on, and they're payers and hospital associations and things like that. So I've written 4 proposals to them, 3 for cardiac and 1 for thoracic. And they are highly recognized and appear to be top priorities, but we're sort of in the middle of the conversations right now. Both models that I sent, or the cardiac and thoracic models, involve the heart team approach like we do with TAVR. We're moving that over to lung cancer care team approaches, which is something that ignited interest at HHS. When the TAVR National Coverage Determination came out and there was a heart team concept in it, there was a rifle shot through HHS. I got more calls saying, like, what have you been thinking? Why haven't you done this 20 years ago? And so they want everybody to have these team models to healthcare, to treating patients. So for us, the 3 that I wrote were fee-for-service shared savings, surgical episode bundled payment shared savings, and longitudinal disease management shared savings, where we actually bring in cardiology to work together as a team and create cost savings protocols for, say, coronary artery disease, like who gets stented, who gets a CABG, how many do you do, how many times do you have to do this, that, and the other. So that's in their order of complexity. So with the APMs, with the legislation that initially came out, was a 5% bonus for participating. So that's a lot, 5% update for your physician fee. And you don't have to, you're not subject to the value modifier once you're in an APM. So all that threats about 2% reduction go away. And then the shared savings allow you to share in the savings that you generate for the hospital and yourselves. And that's indeterminate, you know, where it is. But when I wrote the ACE demonstration and the other shared bundle payment demonstrations, it was up, and the Office of Inspector General agreed to a 25% increase over your Medicare allowable. So I'm up any time for getting a 30% increase in my pay anytime you want to do it. So our future is to work with your hospitals to make certain they earn back their withholds. Hospitals should work with the MD workforce to help them achieve success through appropriate infrastructure support. Create shared savings programs that allow interests of both, align interests of both, and strongly consider designing your own pilot program, because this is a wide open field. You just write it, submit it, and it'll go to CMI, and it'll be considered. There's no lock on who can do it. Anybody can submit one. Stanford could develop a pilot program that you think is important for your institution and have it, you know, design it. Think if it's unique and it delivers care in a different way than you haven't delivered before, it'll get attention, and there's funding for it. Remember, there's $10 billion. And Congress recently called CMMI and says, what the heck have you done with the $10 billion? You haven't done anything. So they still have $10 billion in the bank, $10 billion in the bank. So just wanted to say thanks to Craig, who's been a mentor for a long time and, you know, has driven me to places I shouldn't go. And when I took this job at CMS, he called me, like in Craig Miller fashion. He says, what the heck are you thinking? I mean, what do you think you're going to accomplish when you go there? You're only going to be there until the next administration. What's wrong with you? I said, Craig, I don't know. If I don't do it, I don't know. I can't answer that question, but I'll go there and find out if I could do anything. And I was surprised that we got as much done in a year, because I was hired for one thing, and that was value-based purchasing. And they just gave me a staff, they gave me a front office, and that's all we did. We just worked on it, you know, day and night. I'm trying to get these done. And to Scott for his mentorship and support for me throughout the years and during training. And he's much more measured in his response to the things I've done, but you can tell when he's talking to you that he thinks I'm as crazy as Craig thought I was, but that's pretty good. And then, of course, Phil, who's the best kept secret here. You can't find a picture of the guy. So So thanks to Phil and Ed Stinson and Jim Mark and everybody else on the Stanford staff who's helped me develop a career. So thank you. I enjoyed it.
Thank you for that incredibly educational lecture. I think we have a couple minutes for maybe a few questions. No? Okay. Well, I have a couple questions.
Sure.
One is about research. So with all of the mandated electronic medical records and centralized reporting, is there, there must be thoughts about how to utilize this data for not only improving healthcare, but also for academic research purposes. Do you know of any of these sort of organizations that are tied in directly for this?
So RAND Corporation, who's working on these alternative payment models, does a lot of that, and they help people set up their research initiatives, and they have a huge and a very impressive database and a lot of infrastructure support for that.
Next question's political.
Okay.
So you did mention that with every change in Congress, everything goes away.
The pending bills, not the things that are there.
So do you see any changes on the political landscape? I'm asking you sort of to look into the future that would alter any of these curves and pathways and plans for implementation of various penalties and metrics, where someone could come in and reform this or simply take elements of the law away?
Of the Affordable Care Act? It takes an act of Congress, because it's a law, so it's implemented, and so you would have to have an act of Congress to reverse it, and that's not going to happen. Yeah. Depends on where the balance of power goes in the Senate. You know, if it goes to the Republicans and they retain control of the House, then we could be in for some real funny places. But the issue is that all these things I've told you about are already implemented. They're underway. They're built into the payment systems. It takes an enormous amount to change those payment systems. Just for instance, when I was at CMS and the physician fix was going to be cost 11%, it was going to be 11% reduction in pay, and I called Congress and all the people who were making, deciding on this. I says, look, this is May. I'm going to give you to the middle of June. I need you to tell me what you're going to do. Is it going to be 0%? Is it going to be minus 11%? Or is it going to be a 1% increase? Because I have to create system logic and software to make this happen in the payment systems. And they says, well, we don't know. I says, well, that's great. So I had to hire infrastructure and IT people to write 3 programs, 2 of which I know I was going to throw out. And I'm talking about tens of millions of dollars. And on June 14th, I told them, I have to put something into the system. This is the point of no return. It's like a plane, and you can't turn back because you already lose your fuel. So I said, on June 14th, something's going in there, and I'm going to put 11% reduction in there. And they said, well, we don't know. So on June 29th, they're calling me, the White House is calling me, and some of the finance committee members or staffers are calling me, can you change it? And I says, you didn't read the letter, did you? That I sent you a month ago. And so what we had to do is I put in an 11% reduction. Then I had to go to Congress, and I had to get them to agree to freeze physician payments for 2 weeks. Some of you may remember this. You didn't get paid for 2 weeks. And that took me, in those 2 weeks, I took out all that system logic and put in the 1% increase that they gave. So I don't know if that answered your question, but go ahead, Scott.
So it's pretty clear that a lot of this happens because physicians are uninvolved with the whole process. They just want to do their job and let government do their job. So when you were in Virginia in a smaller sort of center, could you affect physician involvement within your hospital, within your cadre of cooperating hospitals to try and be more proactive?
Mm-hmm. Yeah, show them the money.
Yeah.
So we did a pilot program at Centera, and Ellen Spear did one at Inova, where we did bundle payment for self-insured big businesses around the area. And we created treatment pathways. And I said, I'll be happy to do this, and I'm happy to write all these pathways, but I want to apply it to everybody. I'm not just applying it to the Newport News shipyard and Eskimo Pie Company employees. I can't do all the biopsies. So we applied it to everybody, Medicare beneficiaries, and their profit margin went from $3 to $20 million in 2 years. And same thing happened at Inova. So I said, my God, why don't we do this for the biggest payer, Medicare? And that's why I organized a state and decided to write the demonstration project. And when you showed them those figures, and I met with every CEO of all those hospitals, 17 hospitals, They got it, and they were supportive of it. So show them the money, and you could get them activated. But if you tell them to do this for nothing, they're just sit around and do nothing. Hey, Craig.
We're real proud of you, boy.
Despite what you thought.
Tell us the funniest story in the congressional staffers and the congressional hearings. What's the most absurd and funny?
Okay, so I told this story already. I think you and I talked about it. So here I am. There's something called the hospital wage index, and every year that hospital wage index is applied to hospitals, and your payments are adjusted based on the wage index, which is decided by Congress. Congress decides it and gives it to me. And then I apply it into a formula, and then I decide, you know, how to redistribute the money. So some years, I mean, it's funny, it's tough legislation because it impacts academic versus non-academic, rural versus metropolitan. So one year, it negatively impacted rural hospitals. So I get called by the congressman, and he's in the eastern state, eastern seaboard. He's got the Appalachian Mountains running right through his state, and on the west side of the mountains are rural, and those healthcare systems are getting whacked by this provision, which I had no control over because all I did was apply it to the formula. So he called me, he said, you need to come to my office, and you're going to meet these gentlemen because you're really hurting them. So I go there, I meet the CEOs of 8 hospital systems on the western part of the state, and he is tearing me apart. I mean, vicious, you know, sitting next to me, you know, spewing spittle and saying, how could you do this to, you know, people, and you're destroying healthcare. And I said, wait a minute, let me tell you one thing, Congressman. I work at a hospital, and I want my hospital to be strong, so I'm pro-hospital. I'm not negative hospital. I'm not anti-hospital. I said, but, you know, and the night before I spent like till 3 o'clock in the morning researching this. I said, but the really strange thing about this, Congressman, is that you sponsored the bill in which that factor was put into. And he looked at me, and his jaw hit the table. And his staffers are crawling under the table. Because he sponsored that very bill that did this. And so I patted him on the shoulder. I said, Congressman, it's 10:30. If you go to the Hill, get your colleagues together, and give me a new vote, a new congressional bill by 4:30, I promise I'll have it changed by 5:30. And I got up and I left. So what had happened the night before, I read through all the bills, and I couldn't figure out, you know, what was going on until I finally found that he was the guy who sponsored the bill that actually did this. So that is just, and maybe not funny, it's sad, because it shows you how broad they are. They're 3 miles broad and an inch deep, and they don't really get into it. They don't even know what they're sponsoring in their bills. Right. So it really wasn't Congress, it was Social Security and Administration that took it away. They got a new head lawyer there, and he looked at the law and said, this is illegal, what we're doing. And they pulled it away. And he's convinced Congress that, you know, Congress is not supporting it. We've gone to the Hill, we've lobbied the Hill. We're trying again, you know, we're hoping with the new Congress we can get it back installed so that we can use it again. Everybody realizes that it's a big deficit for us right now not to have that in order to conduct clinical research going forward. So it does a little bit. It's a little bit hard. I mean, there are a lot of things that you haven't seen that go on where, you know, the only ways that I felt I could modify behavior was through shame or pain. So if I really thought something was going on wrong, I put their names in the newspaper and said, you know, Stanford or Centera is doing a horrific job, and just put shame on them to make them change, or to hurt them in the payment system. So I would ratchet down payments for a particular procedure until they just stopped doing it. And that's the way CMS can do it, but it's difficult for them to, they don't want to control physician behavior. And when I was there, it drove me crazy that the percutaneous intervention by cardiology was running off the reservation. I don't mean to say anything bad about cardiologists, but there were people that were doing it inappropriately. And I went to the Secretary of Health, I said, we need to stop this. And, you know, he said, I can't. It's too politically hot. I can't tell cardiologists who are well-educated professionals how to take care of their patients. That's not my job. It's the job of professional societies to control themselves. So controlling physicians at the CMS level is very different. It's very tough to climb that hill there. But one way to control it is to reduce reimbursements. Just like you saw with TAVR, you just ratchet it down, or with MitraClip, are you going to MitraClip rollout at? Well, the MitraClip is going on sale for $31,000, and they got assigned to a DRG for mitral valvuloplasty, which is $13,000. So the minute you roll that patient in the cath lab or wherever in the OR and put a clip in, you've lost $18,000 without even caring for that patient. And that's the way they're controlling it. They said, we can't say no because the FDA panel said you should approve it. We'll just modify the payment system. So it makes it pretty tough to want to do it.
But why keep the MitraClip? Why they get away with charging just a tiny piece of data?
Well, okay, well, it came from Abbott. So Abbott Vascular priced it out. And I met with Abbott Vascular 2 years ago, and I went over this. I told them that this is immoral, what you're trying to pull off here. How could you do this? So they said, well, look, the arithmetic is simple. You make $20,000 for every mitral valve repair you do surgically, and you're going to lose $40,000 for every MitraClip that you do. So just do 2 repairs and 1 MitraClip, and you'll break even. And I said, wait a minute, I'm going to do 20 MitraClips and 40 open repairs and break even? And that's the logic that they're using to promote it.
And the likeness to the PET-C payments. I mean, how are these companies allowed somehow to put in payments that single-handedly double the entire Medicare pharmaceutical budget? The PET-C payment from the beginning.
So it's called lobbying. The 2 most powerful lobbying groups in Congress on the Hill are the Hospital Association and industry. And we could never stop the Hospital Association. I'm telling you, I've talked to other administrators and they said, you forget it, don't even try. I mean, they'll run over you like a truck over, an ice cream cone. So don't even try. I mean, and the industry, when I made changes to some of the payments for some of the things that they were selling, like oxygen, charging crazy amounts for oxygen tanks and things like that, and we were having to pay it, I stopped it, I changed it, I reduced it. The industry went to Congress, and they got people in wheelchairs on oxygen. And they put them on the steps of Congress, and they shut their oxygen off. When they brought out the congressional member and saying, look what they're doing, look what CMS is doing to these poor people. They're gasping for breath, and they were, because they shut their oxygen off. And guess what? I got run over. Congress called me, and I just got beat up. You just get beat up, and I had to reverse the whole regulation. So, yeah, it is. It's lobbying. Sometimes it's immoral what they do. Same like with wound vacs. They put wound vacs. Wanted to get it's basically an aquarium sponge, right? Aquarium tank pump and a sponge, and it was unbelievable how much we were paying for it. And in order to get Congress to write a bill to support it, they were bringing in pictures and patients with big gaping wounds, and they had staffers, congressional staffers, throwing up in the office. And they said, if you don't approve this is what's happening to the Medicare beneficiaries. And so they approved it. Great. How bad a mistake it could have been? At the NCD or just the technology? Well, there's creep going on now because now right now you have industry, putting creep into it, and you got providers doing it in lower risk patients, and they're lower risk STS score, and they say, oh yeah, but my eyeball test says that they're higher risk, and so they're getting that, and then they're writing trials, through the IDE, through the TVT registry to try and look at lower risk patients, and I heard last night it's even going down to 3% risk, for TAVR. So I think we did a pretty good job controlling it. When we wrote it, I looked at the environmental landscape. It looked like about 400 institutions would qualify for TAVR, and there was only one state where there wasn't TAVR coverage, and so 2.5 years later, Edwards still won't talk to me because they can only roll it out in 330 institutions. It's controlled the dispersion of the technology, but they're manipulating it now by reducing risk and hoping that's going to make it better. The NCD still stands as it is. Yeah, well, if industry had it their way, they'd want it to be 1,000, but.
But is CMS going to act on the NCD by reimbursement?
So you and I we could become auditors, and then we could share 1/3 of all the recovery payments that we can find out there. We were talking about this last night at dinner. So CMS, this is interesting. If you let me go this pathway, we adopted a pay and chase position on fraud. I used to sit there and I used to see it happening. I'd see blips on radar screens and I knew something bad was going on, and we'd pay them and then we'd figure it out and we'd chase them and try and get our money back. That's because we only had $5 billion for the infrastructure to monitor fraud, and we spent all of that on information technology to help monitor it. And we didn't have anything to implement it out in the field. Now there's more money in the Affordable Care Act. I do like that. They put in a lot more money to combat fraud and abuse, but that's what the RAC auditors are about. They're independent people who go out there, they're bounty hunters. And that's how the ICD thing uncovered. That's how a lot of people, RAC auditors, make a fair amount of money by uncovering these kind of things. So if I was thinking last night after I got dropped off, I said, maybe I should just quit doing what I'm doing and become a RAC auditor, because I'll get a list from you and for everybody of who's making all these bad decisions, because you should not be getting paid. If you're hospital, if you're running off the reservation and doing it off label, you cannot submit a bill, or else it's fraud. And if you keep doing that and you get caught, what's the consequence for a hospital that is condemned for Medicare fraud? You cannot get Medicare reimbursement for any patient for a decade. You're eliminated from Medicare for 10 years if you're convicted of fraud. So people don't know, they don't realize how big of a deal this is. And if they're running off the reservation and they get caught, it could have serious consequences, very serious consequences. I wouldn't want to be working at the hospital where that happened, looking for a new job.
Well, great. Thank you again for sharing your wealth of knowledge and experience.
Yeah, sure. Thanks.